Hi everyone, welcome and thank you for taking time out of your busy schedules to join us for this live webinar, Diabetes and Family Planning. This session is part of Managing Diabetes, ARHP's 5-part course on the reproductive health implications of diabetes. My name is Priya and I'm the Membership and Education Associate at ARHP. I'll be moderating this webinar. Before we begin, I'm just going to make a few housekeeping announcements. If you called in using a phone and you get disconnected, please dial back into the number listed in your GoToWebinar registration email. If you have immediate questions regarding the webinar technology, please type them into the chat box on your screen. There will be a question and answer session at the end of the presentation. We look forward to answering your content-related questions at that time. An hour after the webinar, you'll receive an email from GoToWebinar with a link to the post-test survey. Now, this is important. Your continuing education certificate will be generated upon completion of this survey. And in 6 weeks, you'll receive a follow-up assessment to gauge how you've integrated competencies into your practice. Finally, please note that this session is being recorded. The recording will soon be available to view on demand on the On-Demand Webinars section of ARHP's website. At this time, I would like to introduce Lori Gowron, today's presenter. We're really thrilled that she could join us today. Dr. Lori Gowron is Assistant Professor in Obstetrics and Gynecology at the University of Utah, specializing in family planning and complex contraception. She completed her OBGYN residency, fellowship in family planning, and master's degree in public health at Northwestern University. She has a research interest in reproductive planning and contraception use in women with chronic diseases. Dr. Gowron is also Section Chief of Gynecology at the Salt Lake City Veterans Healthcare Administration and cares for patients through Planned Parenthood Association of Utah. Dr. Gowron, Lori, you have the floor.
Thank you, Priya, and thank you to everyone who's joined us today for the webinar. As a family planning specialist, I might be a little bit biased in the statement, but I really believe that the topic of reproductive planning is one of the most important things that you can address with your patients. And so I'm glad that you've joined us to learn more about this. We'd just like to acknowledge the commercial support of this session, which was made possible through an educational grant from Merck. This is the list of our planning committee members, as well as our support from ARHP with no significant financial disclosures. And this is an overview of our lecture today. One of the reasons that I think this is so important is because diabetes is really a disease that we can make significant impacts in how pregnancy outcomes go for these patients, and for a lot of different reasons. We know that pregnancy outcomes are best when diabetes is well controlled beforehand. And we also know that pregnancy is sometimes a huge motivator for women to make those really hard lifestyle changes that you've been nagging them about in clinic appointments, such as weight loss, exercise, dietary changes. And also, most importantly, these lifestyle changes and the disease control that these women achieve ahead of time will directly impact another human's life and long-term health outcomes. So our learning objectives around this are to discuss some contraceptive considerations for women with diabetes, and then also discuss preconception counseling and the overlap between these two issues. So first I'd like to introduce you to the one key question. And the reason that this is so important is because in these conversations with patients, you need to be able to identify a woman's intentions for pregnancy and conception and timing around that, and also ensure that their intention matches their use of contraception and also the contraceptive method's efficacy. It's also really important to remember that women's sexuality may be fluid throughout their lifetime. And so even though a woman may identify as having a same-sex partner at one point, she still needs counseling around reproductive planning because she may desire pregnancy or she may have a heterosexual relationship in the future. So providers can really open the conversation about these issues by asking the one key question, which is, would you like to become pregnant in the next year? And the responses to this, if you look through the additional information through the Oregon Foundation for Reproductive Health, take you down an algorithm. For the woman who says yes, it's important to talk about preconception counseling and get them to act pregnant before they become pregnant. For a woman who says no, this opens the conversation about contraceptive options and efficacy. And for a woman who's ambivalent about pregnancy or may not be actively preventing but not actively trying, this is a woman who needs some additional counseling, especially preconception counseling, because a pregnancy can occur at any point. So the role of preconception counseling is really important for identifying and modifying risks that can affect pregnancy outcomes. Now, this is important for all women of reproductive age, regardless of whether they are trying for pregnancy or not, because unfortunately in this country, nearly half of all pregnancies are unintended, meaning that they are either unwanted or the woman didn't want to become pregnant at any point in her life, or they're mistimed, meaning that she did not want to become pregnant in the next 12 months. Now, the mistimed pregnancies, as you can imagine, for a woman with diabetes, can put her at significant risk for adverse disease-related outcomes if her disease is not well controlled. So it's important to talk about pre-existing health conditions and generally make these decisions and lifestyle changes long before planning for pregnancies, because some of these changes take time to happen, such as weight loss or smoking cessation. And also folic acid supplementation must be initiated prior to 6 weeks gestation to be effective at reducing the risk of neural tube defects. Pre-existing type 1 or type 2 diabetes have been shown to affect the risk of congenital malformations, preterm delivery, and neonatal mortality. And again, obesity prior to conception increases the likelihood of preterm birth and low birth weight. So risk modification prior to conception can really mitigate these increased risks of diabetes and obesity. So a big part of preconception counseling is really risk assessment. And there are certain checkboxes or categories that need to be reviewed with all women. First of all, their reproductive history, such as a woman who has recurrent pregnancy loss or preterm delivery. She might benefit from additional treatment to improve reproductive outcomes in the future. Assessing for environmental toxins. Even if a woman can't completely avoid them, there are different methods to reduce exposure. Reviewing the patient's medication list to assess for teratogenic medications such as ACE inhibitors or statins. Talking about nutrition or any special dietary choices the woman's making, such as a vegan diet, which might affect her nutritional needs. Assessing for eating disorders, which can adversely affect pregnancy outcomes. Again, reviewing folic acid intake and talking about weight management and a healthy weight going into pregnancy, and the importance of exercise beforehand and throughout pregnancy to improve obstetrical outcomes. Additional categories include reviewing genetic conditions that could be common in this woman's family or her partner's family, potentially referring the patient to genetic counseling. Talking about family history, reviewing her substance use histories around smoking, alcohol, and also illicit drug use, and then getting chronic diseases optimized beforehand, especially in the setting of diabetes. Checking in about any infectious disease exposures, vaccination history, reviewing issues around family planning in the past and as well as going forward. Talking about mental health considerations, and this is really important in our chronic disease population. For example, women with diabetes have double the risk of depression than women without diabetes. And this is true for many other chronic diseases. So making sure that their mental health is in a good place and their medications are potentially optimized for pregnancy beforehand so that you're not dealing with acute events during pregnancy. And then addressing social concerns is another risk assessment aspect of preconception counseling, making sure the woman has good social support, financial support, assessing for domestic violence, and all of these other issues that need to be helped ahead of time in order to improve pregnancy outcomes for that child. So once you're done with your risk assessment and getting a sense of what's important in this woman's history, there's some general health education and promotion that needs to be done for every woman. Family planning is highly important because we want to minimize that risk of unintended pregnancy and also make sure that we're optimizing everything else before we stop contraception and start the process of attempting conception. Reviewing healthy diet, activity, weight management, folic acid, immunization, talking to patients about the importance of early prenatal care. If you do have a positive pregnancy test, making sure that they're coming in early in the first trimester so that we can not only make sure that the pregnancy is developing appropriately, but also if some of these lifestyle changes haven't happened, we can continue to work on optimizing them. And then also talking to the woman about available support programs if relevant, so she can get on her feet before she plans for a pregnancy. So I'd like to open a poll with a question: ophthalmology exams should be included in preconception and pregnancy care for diabetic women. And the answers are true or false. And so we'll give you a minute to answer this. Okay, so it looks like 93% answered true and 7% answered false. So let's go into some considerations for women with diabetes, including addressing this question. Really, pregnancy and conception is all about timing for women with diabetes and optimizing their disease ahead of time. There are specific considerations for women with diabetes, including managing high blood sugars and minimizing exposure to teratogenic medications because of the increased risk of congenital anomalies with these. And so pregnancy planning also allows for tight glycemic control, medication changes, stabilizing comorbidities, and beginning folic acid supplementation before conception. Women should also be advised to let their care team know before they're considering pregnancy or stopping a contraceptive method, and especially let them know as soon as they have a positive pregnancy test. Now, many centers have a multidisciplinary support group to manage diabetes in pregnancy, and it's not unreasonable to have that woman evaluated and integrated into that group even before pregnancy planning starts, so that she knows what resources are available and how best to optimize her health ahead of time. A1C levels of 7% should be achieved prior to pregnancy and 6% during pregnancy, which is tight control as long as this can be achieved without hypoglycemia in the patient. Now, for type 2 diabetics, glycemic control is often easier to achieve than in type 1 diabetics. But at the same time, type 2 diabetes often comes with many other comorbidities, such as obesity or hypertension, that make the risk of adverse outcomes as high or even higher than women with type 1 diabetes in pregnancy. Now, if a woman has not had a baseline ophthalmology exam in the recent year, we recommend that during the first trimester and then monitoring every trimester throughout pregnancy as indicated by the degree of retinopathy. Again, if she's presenting in the first trimester and has not had preconception counseling, making sure that any teratogenic medications are stopped or changed to pregnancy-appropriate medications. And also prescribing prenatal vitamins ahead of time. There's a recommendation for all women to take 400 micrograms of folic acid daily, and some diabetes management guidelines recommend taking at least 600 micrograms. When it comes to preconception testing for women with diabetes, much of the testing is similar to women without a chronic disease. We test for rubella, we do STD testing, we do blood typing. But for women with diabetes, we're also looking at the A1C level, we're looking at kidney function, and also looking at thyroid function due to the increased risk of other autoimmune diseases with diabetes. Let's go back to the issue of unintended pregnancy in the U.S. For the first time in many, many years, we've actually made some headway on this. But unfortunately, still 45% of pregnancies in this country are unintended. This rate was 51% in 2008. And there are significant disparities in who's affected by unintended pregnancy. Women of color and women living in poverty are much more likely to experience unintended pregnancy than other women. But also in other studies, we've found that women with chronic medical conditions, such as diabetes, are also more likely to experience an unintended pregnancy, which can definitely affect pregnancy outcomes for these women when preconception planning has not occurred. We know that the most effective way of preventing an unintended pregnancy is through consistent, highly effective contraceptive method use. And so this is a graph that was modified from the WHO graph showing the efficacy of contraceptive methods. The methods that are the least user-dependent, such as the implant or the IUDs, are as effective as sterilization but reversible, whereas those that require a patient to do something every day or at every active intercourse are more likely to have a higher failure rate. So for a woman who's on a teratogenic medication for whom a risk of 18% failure rate with condom use is not appropriate, it's important to talk to her about the effectiveness of her contraceptive method and the importance of using a method that decreases that risk of unplanned pregnancy even while she's trying to contracept. So which contraceptive methods are best in diabetes? It's important to remember that the risks associated with pregnancy, especially an unintended pregnancy in a woman with a pre-existing medical condition, outweigh the risks associated with use of any method of contraception. So it's important to consider this issue when you're talking to patients about contraceptive method selection. Even if a woman only wants to use a less effective method, it's still better than no method at all if the outcome is an unplanned pregnancy. So women with diabetes are eligible for contraceptive methods that do contain estrogen. So the estrogen-based methods are combination birth control pills, the transdermal patch, and the vaginal ring. But first-line recommendations should be highly effective methods, as we reviewed in the last slide, such as IUDs or implants. Now, the hormonal-based highly effective methods, such as Nexplanon or the hormonal IUD, do not contain estrogen. And so not only are they highly effective at preventing pregnancy, they do not increase the risk of blood clot. For some women with diabetes, especially those who have complications with diabetes or who have had a prolonged time with that diagnosis, they might be more likely to have a blood clot, and therefore estrogen-based methods may increase that risk as well. So there's something called the CDC's medical eligibility criteria, which we'll go into a little bit further later on in these slides. But what this does is it ranks contraceptive methods' safety by the method type and by different chronic diseases that can occur in reproductive age women. And so for women with a history of gestational diabetes, estrogen-based methods get a Category 1 ranking, or a medical eligibility criteria 1 ranking, which is the MEC on the slide. What that means is that there are no restrictions for use of estrogen-based methods in gestational diabetics. For patients with diabetes who do not have any other complications, estrogen-based methods are can be used, but some follow-up may be necessary. Using a method that outweighs any vascular disease or a prolonged diagnosis, typically estrogen-based methods are Category 3 or 4, meaning that for Category 3, they're usually not recommended, but you need to use your clinical judgment patients and discuss each method. Category 4, though, means not used methods, and they are restricted due to income. So the next slide is contraceptive considerations around obesity. Sorry, we're working on slide advancement here. Because obesity, in some, there is conflicting evidence on this. So there are slightly higher risks. But still, that a method is better than no method. So no information was available in these women. But subsequent studies, especially coming from the Choice Project in St. Louis, actually found that the implant remains highly effective in obese women and that the hormone level does not depend upon BMI and does not decrease based upon higher body weight. Regarding weight gain with contraception, the ACOG Obesity Project attempted to look at studies around these issues and really found that for most methods, there's no clinically significant increase in weight because of the method. The one exception to that is Depo-Provera, which is the injectable method that we have on the market in the U.S. And there is some increase in weight in some patients using this, especially in teens and obese teens. And so if there's a significant concern about weight gain, especially in an obese patient with hard-to-control diabetes, it's important to consider that side effect into their counseling and have short follow-up with them to assess weight gain if they are going to use this method. Okay, so I think we're ready to open another poll, which says LARC methods, or long-acting reversible contraceptive methods, such as the IUD or implant, are first-choice contraceptive options for diabetic adolescents. True or false on this one, and we'll give you a minute to answer. Okay, so 94% of the respondents answered true, which is great. So contraceptive considerations in adolescence has been a hot topic in research and clinical care over the past many years, especially as access to IUDs and implants has expanded. We know that adolescents may be at higher risk for unintended pregnancy, especially type 2 diabetics who could be more fertile earlier on because obesity is related to earlier puberty. We have, similar to the general population, made significant strides in decreasing risk of unplanned pregnancy in teenagers, but it still occurs at a greater rate than the general population. And therefore, the American Academy of Pediatrics and American College of OBGYN recommend long-acting reversible contraceptives as first choice for adolescents, regardless of whether they've initiated sexual activity. Providers are encouraged to counsel adolescents by discussing the methods that are most appropriate for this age group in order of effectiveness. So similar to that chart, we talk about the highly effective methods as first line, and then go through the short-acting methods and barrier methods. And it's important that they choose relationships and encourage condom use to prevent STDs, and also recommend routine STD testing, especially once they become sexually active. There are still many myths that persist about the use of IUDs in adolescents, and we have large data sets now that show that these are truly myths. IUD use in adolescents do not increase the risk of STDs in these patients, and they are not more likely to initiate or to engage in high-risk sexual activity just because they have a long-acting method in place. It's also important to consider access issues with adolescents. Many patients might have confidentiality issues about talking about these methods with their provider, especially if there are concerns about using their parents' insurance. But depending on state, providers can supply contraceptive methods to adolescents in most settings without parental consent. It's also important to address any staff discomfort about providing contraception to adolescents, as many support staff, MAs, nurses, may not know as much about contraceptive use in this population. So going on just briefly about the U.S. medical eligibility criteria for contraceptive use. And this was published in the MMWR in 2010, and we're actually due for an update that should be published on this within the next week, when it varies age, parity, smoking status, lactation, etc. So you can go to the CDC website and find guide app that you can download if you search for CDC contraception and put it on your phone, and that way it can provide guidance in a much more efficient manner. The companion guidance that came with this in 2013 is the U.S. Selected Practice Recommendations for Contraceptive Use. Unfortunately, there's not an app yet for this, but you can find this on the CDC website, and it focuses really on how contraceptive methods can be used. There's information in there about how you can be reasonably sure that a woman's not pregnant so that you can provide same-day initiation of the method, or what tests might be necessary for certain patients, or what follow-up is indicated, or how long they need to use backup methods. And so there's some great evidence-based guidance in this to answer questions about use of these methods. So talking to patients about contraceptive counseling really is important in including shared decision-making in the discussion. It's important to talk to patients about their own preferences and dispel any myths that they might have had about a method. Ask open-ended questions about their preferences around pregnancy planning or side effects or previous method use. Provide information on effectiveness and how to use the method. Give context about options. Ensure access to method placement and removal. And also allow time for questions. The issue about method placement and removal is really important to remember when we're talking about long-acting reversible methods, mainly because placing an IUD or an implant is not necessarily a method that a patient can immediately stop, like a pill, if she's not happy with the side effects. So giving her an out, if she needs one, to come back and talk about the concerns that she's having and have a removal if that's what she desires is important in uptake of these methods. We also employ the teach-back method to demonstrate that the patient understands what to expect with use of the method. The teach-back method asks the client pointed questions to verify that essential information has been processed. Some examples that you might want to ask are, tell me about some of the benefits of this method. What are 3 most common normal side effects that women have when they start this method? Or when should you call me? What symptoms are concerning? And this makes sure that the patient has received all the information and processed it, especially knowing which side effects to call about. For some patients, scheduling a recheck visit may actually increase successful use of the method, especially in patients who are unsure of the method or concerned about side effects, or in our adolescent patients. Having a scheduled follow-up helps to establish care with them, continue to build your relationship with them, and also just give you a chance to ask if they're satisfied with their contraceptive method, if they need to change it, or if they're having any other problems, so that you can ensure that they're adhering to it if that's the method that they choose to continue. So another resource for patients is on ARHP.org. It's called Method Match, which is an online interactive tool that helps the user compare different contraceptive methods and provides basic information on each method. A similar resource is bedsider.org. This assists patients in locating evidence-based information, again, and also talks about patient stories. It's really targeted for adolescents or younger adults aged 18 to 29 years old, and it's funded by the National Campaign to Prevent Teen and Unplanned Pregnancy. This also has the benefit of being able to set up reminders where it will send you a text or an email message to remind you about an upcoming task, such as changing your birth control patch or scheduling an appointment with a provider. Many providers are now setting patients up in their exam rooms with these resources on a computer or an iPad before you enter the rooms. That way they have a baseline level of knowledge and can explore some of the different methods. And that way their questions are more targeted towards their interest when you interact with them. So let's move on to a case presentation and talk about some of the things that we've brought up. So this is Yolanda. She's a 26-year-old G1 P0010. She had a medical termination 3 years prior and is presenting to you for an annual well woman check. She works part-time in an insurance office and is in a medical assistant training program for school. She recently had a PAP and STD testing within the past year, and everything was negative. She does have type 2 diabetes that was diagnosed 2 years ago, and she's been managed with metformin for the past year after an attempt at weight reduction was unsuccessful. She is not a smoker, her blood pressure is normal, and she has no other medical history other than the diabetes. She primarily has sex with men, but does not have a regular partner, and has not had any sexual contact for the last 5 months. When you ask her about her contraceptive method, she says she uses condoms most of the time for contraception. She says her menstrual cycles are irregular, with about 6 per year on average, but this is not a concern to her. She did have a menstrual cycle recently, with her last period 4 days prior. So what questions do you need to ask to guide contraceptive counseling for Yolanda? So open a poll here and give you a minute to answer these. The options are, do you want to become pregnant in the next year? What methods have you tried? Both or neither? so 90% answered both to these questions. 8% said, do you want to become pregnant in the next year? And 2%, what methods have you tried? So when you ask her these questions, she says she does want to have children someday, but definitely does not want to become pregnant in the next few years. She's tried combination oral contraceptives in the past, but admits to not being a very good pill taker, often forgetting pills. She wants a contraceptive method that she doesn't have to remember to use, and she doesn't have any other concerns of side effects such as acne. She does report a small amount of facial hair that she manages with tweezing as her only other concern. So given her desire to not become pregnant in the next year, highly effective contraception is especially important. Yolanda does not have any diabetes-associated complications, so she's a good candidate for any method she chooses, estrogen-containing, progestin-only, or non-hormonal contraception. When we talk about highly effective methods, we focus on the risks, benefits, side effects of IUDs versus the implant. The choice between the different IUDs, such as the copper IUD or the non-hormonal IUD, versus the hormonal one really comes down to bleeding profiles. The copper IUD may have heavier, crampier menstrual bleeding with periods, although Yolanda says that this is not an issue and she's never had heavy, painful periods in the past. The hormonal IUD, currently marketed as Mirena, Liletta, or Skyla, may actually decrease bleeding over time and also provide the benefit in Yolanda if she's having irregular menstrual cycles of giving her some endometrial protection to ensure that the lining stays thin throughout her time with its use. Methods are FDA approved for years, 3 years, 5 years, 10 years, but we always remind patients that they can remove them at any point, but while they're using them, there is a is most concerning for irregular bleeding. Some women have persistent irregular bleeding that does not necessarily get better with time like it does with the hormonal IUD. But I always tell patients to give it at least 4 up to 6 months to really give a good trial of this, because most of the time the bleeding is not bothersome enough to really make a change in contraceptive method. The other concern for Yolanda is her current weight. We don't want to give her a method that increases weight for her. And so though we talk about Depo-Provera as kind of an intermediate acting method, longer acting than pills, but shorter than IUDs or implants, the side effect of weight gain would not be optimal for her. So after going through all of the risks and benefits, Yolanda tells you that her cousin has an implant and she'd like to try that method. You tell Yolanda about potential changes to her menstrual cycle and how to manage any concerns. And you've recently been able to complete this on the same day. Her last menstrual period was within 5 days. So you look at the selective practice recommendations through the DC and you do not have a contraction because with the insertion. But you do recommend her to use prevention. The other reason that you want it is a candidate because is unlikely given her options whether she might at first appointment for her. Not only points. So one question is, what kind of birth control method is good for diabetic patients? How about birth control pills if patient prefers? So I think we've talked about that briefly with the concerns about patients with more advanced diabetes or complications in considering estrogen-based methods and risk of blood clots. So for a patient with no complications, birth control pills are a good option. If the patient's obese, they may be slightly less effective in some studies than in normal weight patients, but still a much better option than not using any method or just using a barrier method instead. But for first-line contraceptives for a chronic disease patient, we always recommend highly effective methods such as IUDs or implants. The next question, can a patient switch from one contraceptive method to another on the basis of menses change and cramps? So, when to make the change, and we absolutely do switch methods based upon side effects. But as I had said previously, we really try to encourage the patient to give it some time. With the short-acting methods such as the pills, the patches, the rings, I usually tell people give it 3 cycles, because the first 1 or 2 cycles their body's still getting used to it. Depending on where they started in their menstrual cycle, they might have irregular spotting that usually gets better by the 3rd cycle. And so if you can get that commitment up front and reassure them that most of the time it gets better, then usually they're happy with the method once they get into the 4th cycle. With the highly effective methods such as the IUDs or the implants, again, I usually try to give them about 4 to 6 months with those. Especially with the hormonal IUD, we know that they're going to have irregular bleeding as the lining of the uterus thins over those first few months. And so spotting is normal, it's unpredictable, but it's usually not heavy bleeding. And if you give them some anticipatory guidance and get them through those first few months, most women are very happy with it, and we have very few removals. But you also have to counsel them up front that about 20% of women by 12 months will have no bleeding at all. And if amenorrhea is an undesirable side effect for patients, that might not be the best method for her. And so, yes, we do absolutely change methods from one to the other based upon menstrual cycles or cramping, but we always try to give them anticipatory guidance, and we always try to give them a true trial before switching methods, unless it's a significant adverse event that causes that change to happen. If you have any other questions, you can go ahead and type those in the question box. Okay. So we'll move on to a summary. So it's important to remember all of the preconception risk assessment check boxes that you need to go through. Not every patient is going to have every one of these, but going through and asking to mitigate some of the risks from these up front before they affect pregnancy outcomes. And for diabetic patients, really focusing on teratogenic medications, making sure that blood sugars are very well controlled, and or obesity can really improve adverse pregnancy outcomes. This is a list again of the health education and promotion that all patients should undergo, especially talking about family planning, reviewing contraceptive methods by efficacy, and setting patients up to have a successful trial with each method. Again, reminding patients that not all pregnancies are planned, and making sure that they're making healthy choices in their life in order to minimize risks of adverse outcomes if they were to have an unplanned pregnancy. And then for the diabetic-specific considerations, talking about pregnancy timing, the tight glycemic control, making sure that you have your team in place of how you're going to manage this patient throughout pregnancy, considering an ophthalmology exam if she hasn't had one, discontinuing teratogenic medications if she is starting to consider pregnancy, or if she's at high risk of having an unintended pregnancy, making sure you're optimizing those medications ahead of time is important. And then talking about prenatal vitamins with 400 micrograms as the recommendation of folic acid for the general population, and some recommendations for diabetics of 600 micrograms. I think there are a few more questions if we have, looks like we have a couple more minutes. So I'm interested in referral for nutritionists. If you don't work in a multi-specialty or primary care practice, where would you turn for a referral for nutrition counseling, especially for low-income uninsured clients? And would these nutritionists be able to include diabetes education, or would that be a separate referral, for instance, to primary care? So this is really going to be institution-specific, and I know that there are significant limitations when it comes to insurance coverage for patients. But checking with academic centers that are nearby sometimes some of the homeless institution or homeless healthcare providers will have additional social workers that work with them and can help refer to providers in the community who will do sliding scale fee for some of these services. But then also looking at the Diabetes Association website to get some online resources as well, because there have been some modules that have been created for nutrition support for patients online, and that would obviously be the cheapest, easiest to access depending on where you are. The next question is, do you have any preconception counseling tips for populations with high rates of diabetes? And that's a great question, because many chronic diseases are not they have this time before the diagnosis actually has passed that they're heading down, and you know that without lifestyle changes they're going to meet criteria for the diagnosis in a short period of time. And so just trying to identify those patients up front, identifying risks, making those lifestyle changes of weight loss, exercise, nutritionist referrals as we talked about, and also if they have high rates of diabetes, really focusing on this reproductive planning aspect of it to make sure that if they are thinking about pregnancy, that might be the carrot to get them to make these lifestyle changes happen sooner. But this is really hard to live in denial of the issues until they get the true diagnosis. But talking to them about their increased risk of gestational diabetes, if they are considering pregnancy and haven't been truly diagnosed with diabetes yet, might be another reason that they could make some changes ahead of time. So that's a hard thing, but an important consideration. The next question is, do insurance companies cover switching from one LARC to another? And the answer to that is it depends. LARC coverage for IUDs, implant coverage, has improved under the Affordable Care Act. There are still some insurance companies that have been grandfathered in and do not provide coverage for contraception, especially devices. And there are some religiously affiliated providers who still do not provide coverage and won't at this point be mandated to provide coverage. So considering some of the low-income options in your community, Planned Parenthood often offers sliding scale coverage for these methods. Liletta is new on the market. It's the same IUD as the Mirena, same dose of the medication with just a different inserter. And for nonprofit organizations, they can provide these for patients for a cost of $50 for the device. So it's a huge difference from the other IUDs and implant on the market. And so checking with providers such as Planned Parenthood or federally qualified health centers that provide LARC can allow patients who don't have insurance coverage for these methods to switch or gain access to them if they can't otherwise get it. So the next question is, any considerations for your diabetic client that has been on Depo for many years and her osteoporosis risk? So that's a great question. Depo-Provera has a black box warning on it with the FDA for increased risk of osteoporosis, osteopenia with prolonged use. And since that black box warning was put on there, subsequent studies have come out and really shown that the changes in bone mineral density that happen on Depo are very, very similar to what happens during lactation. It's reversible bone loss. And it has not been shown to translate to fracture, which is the clinical outcome that we're really concerned about. And so we talk to patients about that potential risk. We talk about calcium, vitamin D supplementation and weight-bearing exercises, and that there is this reversible bone loss. We stop the method for them if they're satisfied on it and are doing a great job with compliance with the method, not having any other side effects, then that's not something that we would typically stop for this consideration based upon the current data. The next question is, I've heard various timelines for folic acid, the need to initiate 3 months before conception, 1 month before conception, and I think I heard today 6 weeks estimated gestational age. Can you give us some resources for further reading? So the ACOG practice guidelines provide some guidance on preconception care. The statement today was that it needs to be on board before 6 weeks, so the neural tube closes typically by 6 weeks, and so they need to be taking that ideally from conception through those first 6 weeks of pregnancy. I think that, in a patient that for pregnancy starting, if it's somebody who's nutritionally depleted for many chronic disease reasons or eating disorders, some settings, then starting them on a multivitamin is important with folic acid supplementation in general. Or if it's a patient who you're concerned is not going to know that she's pregnant to start it, or have an unintended pregnancy and not present to care until well beyond 6 weeks, it's always good to just have a patient on that method. So I think that's part of the variation in the timing. The ACOG is definitely your best guidance on that. The next question is, can patients stay on metformin while they are trying to get pregnant and during pregnancy? And yes, they can stay on it, and many patients with PCOS especially are placed on this ahead of time as part of their infertility management, and many of them stay on it throughout pregnancy. And so it's really individualized on what's worked for them before versus whether they're finally starting insulin or glyburide or metformin just with pregnancy. So I would defer that to decisions, but we often care for patients on metformin throughout pregnancy. Okay, any other last questions before I turn it back over to Priya? All right, well, thank you, everyone. And you're welcome to reach out to me through ARHP if you have any other further questions.
Thanks, Lori, and thank you to all our participants for joining us today and for submitting such thoughtful questions. In just a moment, I'm going to tell you how to collect your continuing education certificate. But first, I'd like to direct you to our upcoming webinar. The next webinar in ARHP's Managing Diabetes series will be held on May 18th at 1 p.m. Eastern and will be presented by Dr. Eleanor Bimla-Schwartz. Dr. Schwartz, an internationally renowned expert in women's reproductive health, will present on the management of menopause symptoms in women with diabetes. We hope that you'll also join us for a special roundtable webinar on June 8th, in which we'll discuss frequently asked questions about diabetes screening, treatment, and counseling in female patients across the reproductive lifespan and beyond. Webinar, you'll receive a link to a survey where you can submit all of your questions. We hope that you will, and please stay tuned for this email. And if you'd like to check out more of ARHP's educational resources, please visit our website at www.arhp.org. All of these resources, including today's webinar, are brought to you free of charge. Please help us to keep these resources free, open access, by becoming a member of ARHP today. And now to the post-test survey. You'll receive an email from GoToWebinar 1 hour after this session ends, containing a link to the post-test survey. After completing the survey, you'll be able to print your continuing education certificate. Please be sure to print before closing the window. If you have difficulties printing or retrieving your certificate, please don't hesitate to email us at education@arhp.org. Thank you again for joining us today. We hope that you will take part in other live and on-demand sessions